Okay, good evening, everyone. Thank you very much for joining us this evening. We're going to have a chat about managing the severely obese patient and what you can do and how you can assist your patient. And you're going to be in the wonderful hands of Dr. Benjamin Walvin. So I love working with Ben. He's got a really informative presentation to give you, and I'm going to hand you over into his very capable hands. So welcome, Dr. Walvin. Thank you for joining us.
Thank you, and thank you everyone for joining us. And this is my presentation, Managing the Severely Obese Patient and an Evidence-Based Approach. There'll be a lot of slides initially with the blue background where we'll talk about the evidence for management of severe obesity or morbid obesity, and then at the end there'll be a few slides with a black background, which is a bit of a jolt to just get everyone's attention and reorient everyone, because then I'll start talking through what I do personally and my experience. Very simply, this is probably one of the main takeaways that you want to know is who to refer, who meets the criteria for bariatric surgery. So morbid obesity is anyone with a body mass index greater than 40 or greater than 35 with an obesity-related comorbidity. And almost everyone with a body mass index of 35 or greater will have developed a obesity-related comorbidity. So in practice, it's usually someone with a BMI of more than 35. I would also probably take that, I would take that down to a body mass index of greater than 30 with type 2 diabetes. As we'll see in this presentation, bariatric surgery is extremely effective in the treatment of type 2 diabetes. And if we can catch type 2 diabetes early in the course, in the first few years, the sleeve gastrectomy surgery alone will usually place the diabetes into long-term remission. And just a reminder, body mass index is the patient's weight in kilograms divided by their height in meters squared. We'll go through all of this, and there'll be an opportunity to ask questions at the end also. So severe or morbid obesity, what is it and why should we intervene? So this is a bit of a multiple choice. Is morbid obesity or severe obesity a character disorder? Is it sin, gluttony or sloth? Or the correct answer is it C, a normal physiological response by epigenetically predisposed individuals to our modern obesogenic environment. So epigenetics means that the genes have been switched on or off before birth by the experience of recent ancestors, and that in combination with genetic predisposition will lead some individuals to develop morbid obesity. Our environment does not encourage exercise, though that is improving. And since the 1960s, the cost of easily digested non-filling carbohydrate calories has plummeted. So we've gone in a short period of time, in 40 or 50 years, from an environment where most people didn't have enough food to an environment where now most people have too much food. So our problem is not food shortage, it's food excess. Although there is a maldistribution of food in the world, obviously. So we can classify people by their body mass index. Normal BMI is 18 to 25, 25 to 30 is overweight, greater than 30 is obese, and greater than 35 with an obesity-related comorbidity is morbidly obese. And to give you an example of how this looks for a 6 foot tall male patient or 6 foot tall patient, 84 kilograms is the top limit of the normal BMI. And I think we'd agree most people that we see that are 6 feet tall that are adults, probably heavier than that, or that heavy or heavier. So what this tells us is that these elevated BMIs have become our normal. So people with a body mass index of 18 to 25, particularly 18.5 to sort of 22, look quite skinny to us and underweight, but they're actually healthy weight individuals. We can also calculate the excess weight, which becomes relevant in how much weight we expect with surgeries. We generally express that in terms of percentage of excess weight lost. So with morbid obesity, the risk of developing comorbidities goes up. And that includes a number that you'll be familiar with, especially the ones that people are more than 5 times as likely to develop: type 2 diabetes, hypercholesterolemia, sleep apnea, fatty liver disease, intracranial hypertension. These are ones that might spring to mind relatively readily. And but then there's also some that might not occur so obviously to people. Endometrial carcinoma in women is a obesity-related disease. Gallstones. The other one that is not listed in this particular paper is renal cell carcinoma. I routinely perform hepatic ultrasound to assess for fatty liver, and in my series of 1,500 to 2,000 patients I've done this on, I've found 4 or 5 renal cell carcinomas. So renal cell carcinoma is directly caused by obesity. Other ones that I'd like to point out, airways disease, and it's related to reflux often, and acid spilling over into the airway. But the other one is impaired fertility. And fertility is radically improved, especially if it's due to polycystic ovarian syndrome, but due to any problem, female fertility is greatly improved with the weight loss of bariatric surgery. And unintentional pregnancy is actually a risk of bariatric surgery. That's how strong that effect is. So these people face an elevated mortality hazard. We've got the orange line, which shows the mortality of all patients, and then the blue line is patients that have never smoked. So you can see that non-smokers, when as indicated by the green dash lines, when they reach a body mass index of 40, they have a mortality hazard 2.5 times that of non-smokers with a healthy BMI. And as with the old alcohol J curve, you can see that being underweight has a slight elevated mortality hazard as well, but not as high as being obese. That was for white women, same for white men, same for white women. Mortality hazard of a body mass index of 40 is 2.2. Another way of expressing this, we can look at smokers versus non-smokers, and we can see that the risk of a non-smoker dying in a given period at a normal BMI is this, as a smoker at a normal BMI has got the same risk as a morbidly obese non-smoker. So a body mass index of 40 is equivalent to being a current cigarette smoker, approximately, in terms of mortality risk. And as far back as 2010, the third report of the Chief Health Officer of Queensland for the health of Queenslanders, this has been identified. This is the burden of disease across Queensland attributable to 13 risk factors. And you can see that high body mass index is right up there as a leading cause of disease and injury. And type 2 diabetes representing 5.2% of the total burden in Queensland. So what can we do about this diet and lifestyle? How effective are they? Not very, unfortunately. The NHMRC guidelines looked at various diets. Now, things have improved a little bit since this came out, but the problem with diet for weight loss is it's almost impossible to sustain long term, as we'll see in the next few slides. And so that if we don't treat people at all, this top line for weight loss, they'll tend to gain 1.9 kilograms over 3 to 6 years. With various diets, we could get off as much as 6.5 kilograms, which is not much in the context of 30 kilograms overweight that we saw before. And meal replacement diets, which is what we use for bariatric surgery, are the most effective. We use those to prepare patients. Everyone's probably seen these sort of slides. It is starting to level out now, but you can see that the overweight individuals have become more common than normal weight individuals in our community. And now the obese individuals are also more common than normal weight individuals. So this is flattening out now. And you can see the rates of obesity in Australasia. We rank third in the world. for men and 8th in the world for women. So, and you can see from this table, it's very much a in the more developed parts of the world where excess calories are more freely available, that this disease is most prevalent. And this slide really explains why it's very hard to lose weight long-term with a diet or with lifestyle changes, because it's not the conscious part of the brain that makes most of the decisions about food, and the neurohormonal circuitry is very complex. That's also why, although we are improving in this regard, medications have only limited success in causing long-term weight loss as well. So this is an interesting study where patients went on a 10-week diet, and then we see the long-term out to more than until 1 year or 52 weeks later, for a total of 62 weeks, how much weight they were able to keep off. And you can see that in the diet, they lose weight quite quickly, but even by the 8-week mark of the 10-week diet, they almost stop losing weight at that point. So it's had its maximum effect and they can't go lower. And that over time, the weight creeps back on. And that these people who were very well supported in this study and had every help imaginable short of medications and surgery were able to sustain a weight loss of less than 10 kilograms at 1 year follow-up. And if we and that's if we count only the people that completed the course, but the people that dropped out. So the intention to treat analysis, which is probably a more honest analysis, it was only about 5 kilograms. And from this similar study, this shows why. Ghrelin is the hunger hormone. So after you eat at time 0, the level of the ghrelin falls because you feel full and produce less hunger hormone. And then after about an hour, it starts to slowly recover. And by 4 hours, it's back to baseline, which is a fairly obvious pattern. But what's interesting about this is after people did the study, how much ghrelin, what their ghrelin levels were like in relationship to their resting levels, and then ghrelin suppression by eating. And you can see that when they'd first completed their diet, they had much higher levels of hunger hormone at rest, and they did not suppress down as far with food. So these people's ghrelin levels are trying to put weight back on them. They're running higher ghrelin levels and have higher hunger at baseline and at every stage after eating. And pancreatic peptide YY, which is one of the fullness hormones, of which there are several, we see the exact inverse, that the levels of this fullness hormone are lower in people that have been on the diet. And we can see that these changes to some extent even persist out to a year afterwards. So a year after these people have dieted and lost 5 to 8 kilograms on that diet, their gut hormones are still trying to put the weight back on them. And this is not measuring gut hormones, but this is the same thing with questionnaires and then rating how they feel. We can see that even 52 weeks after completing their diet, they still have less suppression of their desire to eat and more hunger at every stage before and after eating. So this is why it's very hard to lose weight and sustain it with diet long term, because there's a set point for weight and the hormones are trying to put the weight back to where they think it should be even a year after losing weight. And almost no one has indefinite strength of will, and so most people will regain weight with time. So clearly that's not the answer. I mean, the answer is societal change, but that's slow in coming. And in the meantime, we need to treat people. Clearly the way of treating people, diet and exercise, can help a little, but it's not going to help the morbidly obese people get back close to a normal weight. So the evidence for bariatric surgery, as far back as 2009, the Cochrane collaboration has looked and found that bariatric surgery is definitely significantly more effective than conventional management with diet and exercise. And the NH and MRC guidelines say that this sort of surgery is effective And although it may appear upfront expensive relative to other treatments, it's in fact one of the most cost-effective treatments available because of the long-lasting effect and the large amount of weight lost. So here's the results expanded, and we can see diet plus activity. We're talking in the range of 1 to 6.5 kilograms at 3 to 6 year follow-up. And then if we look down at the surgery, we're talking much larger amounts. Biliopancreatic diversion, we don't really do much anymore because it is a bit extreme, but 54 kilos. The band 36, and bypass sleeve around the 40 mark. The biggest study we have is the Swedish obese subject study. We're now out to more than 20 years follow-up. And you can see from this that there were 2 arms. There's surgical arms, and unfortunately the sleeve gastrectomy wasn't invented when they first started this study more than 20 years ago. But we can see that the operations that did exist, the patients lost a lot of weight at the start. There was some regain, but they were able to keep most of it off. These patients are highly supported in the Swedish health study, and they have excellent follow-up. They also had a control arm, and these people got the best of non-surgical care of their obesity and obesity-related comorbidities. And we can see that their natural history over 15 years was that they lost almost no weight, while the surgical groups, all, including gastric band, achieved significant long-term weight loss. And this is their mortality risk. We can see right at the start that you may actually have a slight increased mortality from some of the surgeries in the first year or so, because there is no doubt that rapid weight loss at the time is probably not a healthy thing. But over the long term, the surgical group open up a bigger and bigger gap in terms of their chance of having died. These are patients with a body mass index over 40 and with obesity-related comorbidities. And we can see that at 16-year follow-up, that gap has widened to over 5%. So a number needed to treat of 20 to prevent 1 mortality at 16-year follow-up for surgery. Another review: preventive approaches to weight gain are not on their own sustainably effective in treating people who are really severely obese. Any sustainably effective treatment algorithm for severely obese patients with type 2 diabetes should include the option of bariatric surgery. So people are, the obese patients are on the slide. Once they start to gain weight, become overweight, it becomes easy to become obese. And once someone is obese, it becomes very easy to then slide down into morbid obesity. And we're trying to reverse the slide. So which patients are most appropriate for referral? We've talked about this. Generally, people with a body mass index of over 40 or over 35 with significant medical comorbidities, but most people with a body mass index of over 35 have some medical comorbidities. Patients need to be well motivated with acceptable operative risks, and they have to obviously have a strong desire for substantial weight loss. Definitely this is a surgery that more than any other requires patients to significantly buy in, and they need to want this and to be motivated. But by the time they come to me, they are, and they do. Severe obesity is becoming increasingly common. These pictures are quite interesting because they show how almost only slightly overweight someone with a body mass index of 35 to 40 can look to our eyes, because we're used to seeing people who are overweight, and with clothing people can disguise. So these are people with those body mass indexes. And going through some of those comorbidities again, the big ones: type 2 diabetes, hypertension, non-alcoholic fatty liver disease, obstructive sleep apnea, cardiopulmonary disease, cardiovascular disease, osteoarthritis, polycystic ovarian syndrome, dyslipidemia, hyperuricemia is very common, infertility or polycystic ovarian syndrome. So we've already talked about this. It's been standard of care in management of diabetes since 2011 of the American Diabetes Association, that Bariatric surgery should be considered for adults with a body mass index of greater than 35 and type 2 diabetes, especially if the diabetes is difficult to control with lifestyle and pharmacological therapy. Patients with type 2 diabetes, and indeed all patients who have bariatric surgery, need lifelong lifestyle support and medical monitoring. It's a highly effective tool, but these people do still need lifelong follow-up to keep them on track. Just like anyone else, if they try hard enough, they can gain weight and go off track, just like any of us. But and also these surgery is highly cost effective. This is excellent value for money for the healthcare system when we consider the reduction in subsequent healthcare costs from managing chronic disease and its acute complications. I think we'll skip over that. This is some more interesting data. This shows patients with type 2 diabetes and their use of various medications and how that changes after surgery. And you can see that it really plunges. The only thing I tend to see people on long-term is metformin. Sometimes they still take a little metformin, but most patients can, if they're caught early in their diabetes, can come off all medications. And I quite like this graph. So on the left, we have patients that before their bariatric surgery are on insulin. So that's the black bar. So 100% of these patients are taking insulin. And here's our control group where we give them the best of medical management. And we can see that at 3-year follow-up, we have managed to get about 30% of them off insulin, and some are off all medications, maybe 15%, and the balance do take some sort of oral medication for their diabetes. And we contrast that with the pain on the right, the picture on the right, where we start off with everyone on insulin, but instead of treating them with medical management of their diabetes, we treat them with bariatric surgery. We can see that instantly the majority of them are able to get off their insulin, and this number increases with time. And at 3-year follow-up, 75% of patients are still off insulin, and at least 50% are off all medication. And here's the same data, except this is also quite interesting. This is patients that have type 2 diabetes but are not on insulin. They're on oral medication for their diabetes. So we start here, 100% of these patients are on oral medication for their diabetes on the left. And we can see that, quite interestingly, even with best of medical care, these people gradually get onto insulin. And the problem with that is insulin makes them hungry and they gain more weight. So the natural history of a patient that's not taking insulin for type 2 diabetes but is on oral medication is slowly to get onto insulin. And contrast that with the bariatric surgery population, where we start with 100% on non-insulin oral medications, and instantly most of them are able to get off that medication, and more of them get off the medication with time, and almost none of these patients subsequently get onto insulin. And this is really the group I see most commonly. I see, obviously we don't treat as many type 2 diabetics with insulin these days. They tend to be on other agents. So this is representative of the outcomes that I see, which is hugely improved glycemic control, hugely decreased medication requirement, and people not needing to get onto insulin long term. And the vast majority of patients that I treat early in the course of their diabetes within the first few years get off all medication. So once again, bariatric surgery is effective and cost effective for type 2 diabetes and obesity with acceptable safety profile. I'll talk about that. Complications from sleeve gastrectomy in particular have become extremely uncommon. So I'll talk about the different sorts of bariatric surgery. I think that in regional Queensland, sleeve gastrectomy is probably the way to go for almost all patients. So the most common forms of bariatric surgery are the gastric band. Uncommon now, probably do one of these a year. For the right patient, it can still work well. One of the problems is these little sutures that are required over the band to hold it in place. Really results in deformity of the upper stomach, and makes doing further surgery if the band needs to be removed very difficult and more risk than in doing the surgery in a patient that hasn't had a gastric band before. None of these operations cause malabsorption. Gastric bypasses do not cause malabsorption. That's not how they work. But even with the gastric bypass, the patient still has 3 meters of small bowel in continuity distal to the bypass, which is plenty to absorb their macronutrients. They may get some malabsorption of micronutrients, but macronutrients, they're going to absorb them all. The type 2 diabetes effect of the band is really only attributable to weight loss. So it's not particularly strong, whereas the sleeve and bypass are much stronger. And I find even with the sleeve, patients that have not been diabetic for long, under 5 years, almost always resolve. And the patients that have been diabetics for longer, their diabetes at least usually improves, and they're often left only on metformin and a GLP-1 agonist like Ozempic. Hormonal effects of the band are minimal. The sleeve and the bypass, due to rapid gastric emptying into the bowel, cause secretion of more of those foregut fullness hormones. And also the sleeve also causes sustained reduction in ghrelin, the hunger hormone secretion. And the weight loss with the sleeve and bypass are more than the gastric band as well. So I can talk about the gastric band. We don't do it very often. The big problem's durability. This is an implanted device, and like any other device, it can fail. But then, like a fridge can fail, or any other machine you might have. But the band is inside the patient, and then there's an operation to fix. That's the big problem with the band. There are a few people that it can still work well for, and if a patient really wants the band and understands it well, understands how it works, which is that we tighten it to the point that it suppresses hunger. The idea is not to tighten it so tight that it acts as a physical barrier to food. That's not how it works. It's tightened enough to press on the vagus nerves that come through here, and they send us constant fullness signal to the brain. Also, this little pouch here is somewhat restrictive. The patients eat down into a small gastric pouch above the band, and that feels full. But it is not meant to work by making it so tight that you can't eat. So as long as they understand that, we can normally get good durability out of it. And for someone that's only got a body mass index just over 35 and no type 2 diabetes, it can work very well. The sleeve, I think, is the answer for the majority of people. And the reason compared to the bypass is there's essentially no medium or long-term emergency complications. If the sleeve doesn't bleed in the first 24 hours, it doesn't leak in the first 2 weeks, there's nothing worrying that goes wrong with it long-term. That's why I prefer it, especially for patients in regional and remote areas, because if they can't access a bariatric surgeon quickly and they have a complication, that can be a problem. But with the sleeve, we really just need to monitor them closely through that first 2 weeks. And as long as they're well in that time, and I monitor them with blood tests, FBE, CRP, Monday, Wednesday, and Friday, then they're not going to have any problems beyond that are urgent emergency surgical problems. We've also become very skilled in the prevention of leak. The rate should be less than 1% now, and mine's well less than 1 in 300. And the management of the leak, we detected early with the blood tests, and with experience over the last 10 years, realised that the management of the leak is not to reoperate. The management of the leak is transferred to a centre where they can do an endoscope and patch or drain the tiny 2 to 3 to 4 mil hole that always forms at the top corner here. I also reinforce that area with a special reinforcing strip, and that's one of the reasons I've been able to get the leak rate so low. You have plenty of time to transfer these people because we detect them early. It takes a week or 2 to get really sick from a leak usually. It's a very small contained leak, a 2 or 3 or 4 mil hole leaking into a 1 to 3 centimetre cavity usually. And as long as they're put on appropriate antibiotics, they will be and stopped from eating. They will be well enough to be transferred and have that done. The gastric bypass, sure, it's probably slightly stronger than the sleeve. It's also a lot more complicated. There's a lot more things that can go wrong. We've got the staple line, just like the sleeve, which could leak or bleed. We've also made 2 anastomoses. There isn't any bypass with just 1 anastomosis, but any anastomosis adds a lot of complication because it's an unnatural join. Acid from the stomach can attack the joint, causing ulceration, which can bleed or perforate months or years later, by which time Who knows where the patient's living, and will this condition be, will their unwellness be attributed to this? How quickly will it be worked out? How quickly will they get appropriate surgical care? So this can go wrong with ulceration months and years later. Also, if they have a Roux-en-Y gastric bypass, the break and continuity of the small bowel opens up a space behind it where things can, the rest of the bowel can herniate, and that can cause major complications as well. So due to its potential for long-term complications and a lot more side effects and less pleasant to live with the sleeve for little additional weight loss, little additional diabetic control, I think that the sleeve is a better option. Also, a sleeve can be easily revised to a bypass. With a bypass, there is very little revision that can be done. In my 3,000 odd sleeves, I've had to revise about 3 of them to bypass. So 99.9% of the patients, the sleeve has worked very well for them long term, and they have not required revision to bypass. The weight loss of bypass or sleeve is considerably more than band as well, as is the type 2 diabetes remission due to those foregut hormone effects. The rapid emptying of the stomach causes secretion of hormones, a number of foregut hormones that have an instantaneous effect on diabetes, which is why even before there's been significant weight loss, glycemic control and medication use tails off very rapidly. With the sleeve, there's better long-term food tolerance. With the band, there's poorer food tolerance because it has to be tight and somewhat restrictive in order to have its effect. There have been some trials, and once again, the sleeve causes considerably more weight loss over time than the gastric band. And we've really moved away from bands, though there is the odd patient that it's suitable for. This is ghrelin. This is the hunger hormone. You only get these sustained reductions after the sleeve because we remove that upper outer part of the stomach that makes this hunger hormone. You can see that the reduction in hunger hormone is sustained out to 5 years. We contrast that with the effect of diet, where the patients had a higher level of ghrelin hormone after losing weight from diet. So that's one of the reasons for the sustained effect of the sleeve. So hopefully we can get these patients to climb back up from morbidly obese to a normal weight, or at least achieve 60% excess weight loss is our goal, from morbid obese to the overweight category, when they'll be a lot healthier than they are now. With all of these operations, there is a long-term failure rate. These patients need long-term care and monitoring, which I'll talk about as well. So this is more about the black slides now are more about how I do it. So once again, who qualifies for surgery, sleeve surgery, in my opinion, but anyone with a body mass index over 40 or over 35 with an obesity-related health condition, or over 30 if they have type 2 diabetes or especially severe obesity-related disease. So someone who's 160 kilograms, 160 centimeters tall, 100 kilograms, their body mass index is 39, for example. So well into the morbidly obese criteria. The other thing to say is if they've had prior bariatric surgery, say a lap band, they don't need to meet the BMI criteria. You know, if there's been a complication, they've had to have their gastric band removed, we can revise them at any time. We don't have to sit there and wait for them to get sick and morbidly obese again before we intervene. They can be converted to other bariatric surgeries pretty much straight away. A list of these obesity-related comorbidities. These are the ones I commonly see, highlighting kidney and uterus cancer, as people don't often think about, lumbar spondylosis as well, and lower limb osteoarthritis. And I think we've talked about the others previously. So I prepare these patients with an OptiFast diet before surgery to defat their liver. How long I do this for depends on their BMI and the size of their fatty liver. So I calculate their BMI when I meet them. And before I meet them, I get an ultrasound of their liver and get it measured in the midclavicular line on the right. And I need to retract the liver, which I'll show you in a moment. And also we want to make space to the insides generally, especially in males, as they carry their fat females carry their fat under the skin, where it doesn't give us as much problems with as men carry it inside their abdominal cavity in their omentum, where it gives us a lot more problems. So we want to make some space for safe surgery by getting rid of internal fat, and also we want to defat the liver. So to give you an idea, I put people on 3 meal a day optifast for 2 to 3 weeks at a body mass index of 35, and their liver not too big. If they have a high body mass index, 4 to 6 weeks of optifast, and give them some sort of preoperative weight loss goal. It's also really good if they can see a dietitian and sometimes a psychologist in this time, and we have both of those health professionals working in our clinic, and there's others that work independently that we use as well. So with the optifast diet, they replace all 3 meals, plus they have 2 cups of steamed green vegetables per day and unlimited water to drink. And I see them during this time, and they also ideally see our dietitian or another dietitian during this time as well. So this is why we want to defat the liver. This is a great example of a fatty liver in terms of the texture, the bulkiness, and the color. So this liver is swollen with fat, but they certainly get a lot worse than this. This is as extreme an example as you can show, and still see the stomach underneath the liver. But in more extreme cases, all you would see in this entire picture is liver, and then it's impossible to safely lift it up with a retractor to get to this stomach, which is posterior to it. And there can be a lot of omental fat as well. This is a female, so less omentum, but men can have an awful lot of omentum. So this is just a picture of the sleeve. I think this is the best representation I've seen. The staple line starts a couple of centimeters behind the pylorus, or proximal to the pylorus, well proximal to the incisura. It's very important to leave around this angular incisura enough space and not make a stenosis at that point. So I'd actually draw a guideline on the stomach for this section. I follow the guideline with my first firing of the staple, and then place a 36 French calibration tube and follow that the rest of the way, aiming to finish just lateral to the gastroesophageal junction, and then all this stomach around about 2/3, but it depends how big this is relative to the calibration tube is removed, and that includes the bit that can expand to take on food, and it also includes the bit that releases the hunger hormone ghrelin when it's feeling less distended, making us all feel hungry again. And afterwards, there's the food path into the stomach is the same. There's no gastric band constricting food coming in. There's the normal upper lower esophageal sphincter. Food passes through that, but once it's in the stomach, it's a narrow pipe stomach, and a few mouthfuls, sometimes only 1 mouthful of steak, and the patient will feel full and not want to eat more. Also, instead of the food being ground up by this intact baggy distensible stomach and then slowly fed out through the pylorus to the small bowel for digestion, now what happens is some lumps of food that have just been chewed and still very chunky compared to what the stomach would normally grind them down to, because it's a pipe, these chunks pass directly out, or at least some of them, into the small bowel, and that's a sudden appearance of chunky and unexpected food is what causes the small bowel to release about 10 different hormones that induce satiety and also have an anti-diabetes effect, and also activate brown fat to burn a little more energy and increase a metabolic rate as well. With the bypass, we don't keep the pyloric valve. There's just a stitched or stapled connection between the gastric pouch and the small bowel, and that's whatever size we make it, and cannot open and close appropriately, and that's why they get a lot more side effects. So the sleeve is laparoscopic surgery. It's under a general anaesthetic. Over experience of about 3,000 of these cases, I've been able to refine this down to, in the vast majority of patients, 95%, 1 night in hospital only. And they're usually fit to go home the next day. We've just worked out a lot of things, like getting them sipping fluid the same day of surgery, getting them mobilizing around the ward the same day of surgery, keeping them hydrated, giving regular paracetamol, oral endone, and ondansetron to keep pain and nausea under control. Probably the other thing that's really improved length of stay and post-operative course in hospital is not giving patients PCA. When we gave them a patient-controlled analgesia, we found that it just made them nauseous and gave them an extra day in hospital and didn't really make them more comfortable at all. So through early mobility, through avoidance of opioids except oral endone, through regular on-dance-tron, through early resumption of oral intake, being able to get their hospital stay down to one day. I don't do a contrast study swallow routinely, as in patients that have had leaks in the past, I've found that it doesn't show them. And from monitoring their FBE and CRP over the course of the first 2 weeks, I've also discovered that they don't have an inflammatory state in the first few days. These patients aren't leaking straight away. They're leaking after 8 to 10 days. So I don't see the point of doing a contrast swallow at day 1 to detect a leak that it may or may not show even if present, and almost certainly won't be present for another week if it were to occur. It's just an unpleasant and procedure with unnecessary radiation at that point. So afterwards, once again, early resumption of normal activity. People can return to work as soon as they feel ready. Everyone is counselled that they know their job better than I, and they know when they're ready to go back to work. For most people, I would say have 2 weeks off work booked, but they can go back as soon as they like. And someone that runs their own business will often be at home on day 2 or 3 doing a few business-related duties, and most office workers will be back in the office by a week. I'm also happy for light exercise like walking or running as soon as patients feel like they're ready, as long as they realise that they can't get dehydrated from exercise and then expect to gulp a large amount of water. And obviously after surgery, they need to make a slow graded return to exercise, but they can start as soon as they like. Also happy, someone else should drive them home, but they can drive themselves short distances as soon as they feel ready. So they know better than I when they feel ready to, safe and able to operate a car, and I'm happy to do that for them to do that when they feel ready. Qantas guidelines are not to fly for 2 days. I think that's after 4 days after laparoscopic surgery. I think that's due to concern over intra-abdominal gas, but I can tell you from times when I've had to CT people after laparoscopic surgery that there's no gas 24 hours after surgery. We use carbon dioxide, it's highly soluble and it disappears very quickly. So in practice, I'm probably happy for short flights 2 days after surgery. Any flights after surgery for 6 weeks, people should wear compression stockings. The only real hard restrictions in physical activity, no swimming for 2 weeks because the wounds need time to heal up before placed in an aquatic environment, but I am happy for people to shower the same day as surgery and just pat their dressings dry afterwards. And because they've had laparoscopic surgery, no lifting more than 10 kilograms for 4 weeks other than their children, because that's unavoidable, so that we minimise the risk of hernia formation. And as I said, I do 5 blood tests, FBE and CRP, to ensure they don't have a leak. Experience of a couple of thousand patients applied to this protocol has shown me that I wouldn't get concerned unless the CRP was greater than 100 with an abnormal white count, or a CRP of greater than 150 without an abnormal white count. Even then, patients can record those in the first few days of surgery, not have a leak. I've seen people with white counts of 22 in the first couple of days after surgery, or CRP of 100, and there's no leak. So expect the CRP to go up quite a little, sort of 20 to 60 range, and then slowly come down after that. They can't eat normal food straight away. We do get them sipping clear fluid the same day as surgery, but there is 6 weeks where the diet needs to be modified. We don't want to provoke a leak. So the first 2 weeks is strictly liquid, and that's clear liquid for the first 2 days. And a liquid is a runny fluid that would easily go through a straw. Then they go over to 2 weeks of a puree diet. Once again, with these diet phases, we give them written information. I talk to them about it, but it's also really helpful if they can see a dietitian. And I strongly advise a care plan in support of that. So puree diet, like it's been through a blender, or baby food or soup, that sort of consistency. And then 2 weeks of a soft diet. So if it's a meat, it's minced. If it's a vegetable, it's mashed. And they follow up by their surgeon and dietitian for at least the first year of life, and they still have a long-term health problem and need to continue to see their GP for life. And that's probably where I conclude that. Are there any questions? Anyone?
I think you've just been very inclusive, Ben. That was an awesome presentation. Thank you. Has anyone got any questions for Ben at all? No?
Is that as expected for everyone?
If you're trying to ask a question, you might have to take yourself off mute, maybe. Oh, looks like you've completely. Oh, sorry, I'll take myself off. Sorry, looks like you've completely answered everybody's questions. So that doesn't surprise me. It's a very good presentation. So thank you very much. Alrighty, well, if no one's got anything, oh, hang on, I've got something in the chat. What about olive oil for preventing gallstones, Ben?
Oh yes, yep. So risks of rapid weight loss. I didn't really cover them very well. Look, hair thinning, usually noted by female more than male patients, gets better with time and passes. And really, it's a symptom of rapid weight loss. So it's a symptom that they're doing well. You know, I've got standard advice on that, including adequate protein intake of 60 to 80 grams a day. Unintentional pregnancy is another one. Female patients need to take appropriate precautions in the first year to prevent unintentional pregnancy. I've met a number of babies that were conceived in that first year, and it wasn't necessarily planned at that time. If pregnancy occurs in the first year, it can still be progressed. Gallstones is another one. Women have about a 1 in 4 lifetime gallstone risk, men about 1 in 8. Gallstones after bariatric surgery in the first year, certainly I do see that in females. It is about a 1 in 20 risk, I would say, approximately. And yes, I think that daily intake of an oil, I usually advise a fish oil tablet, but olive oil is fine as well, is a good idea. The reason the gallstones that occur after weight loss surgery are almost always cholesterol stones. And so there's lots of little yellow 3 to 5 millimeter cholesterol stones, or even down to 1 millimeter crystals, due to supersaturation of the bile with cholesterol that's been excreted as patients lose weight. Because if you break down the word cholesterol, it's chole, which is bile, sterol, fat. So there's always cholesterol in the bile, but there's too much of it when we lose weight quickly. Also, we're not eating as often, and so the bile tends to hang around in the gallbladder and have more of a chance for it to get concentrated and for the cholesterol excess to form crystals. So encouraging the gallbladder to empty by daily intake of some oil. I prescribe fish oil, but olive oil is fine as well. Can certainly help combat that and is quite appropriate. I also think it's probably good for the hair as well. Oh, sorry, I just can't hear you at the moment.
Sorry, I was on mute. So thank you. So Stephen, does that answer your question? You're very welcome to take yourself off mute and talk to Dr. Walvin yourself. So hopefully he's answered your question. Yep. So I prescribe. I use fish oil, but I don't think there's any evidence for fish oil over olive oil. Olive oil is fine as well. I think anyone who's experiencing significant weight loss should consider that to prevent gallstones. Good to know. Cool. Thank you. All right. Are there any other questions? Okay. All right. Oh, yep. No. Okay. So of course, you can contact Dr. Walvin at the Garden Medical Centre. His contact details are on the Hillcrest website. And if you, by any reason, have any trouble getting in touch with him, please reach out to me. Always happy to pass a message on to any of our specialists here at the Hillcrest. And I know they love to hear from you, so don't be shy. All right, well, Ben, thank you so much for your time. Some really good, great talk. Thank you very much. Thank you, Dr. Vattini. Thank you so much, everybody, for joining us. We might call it a night, and I hope you all have a good evening. Thanks, Ben.
Thank you.
Good night.
Good night.